talk about therapy options for postmenopausal vaginal atrophy. And first of all, I think it's important that you know that you will receive 1 credit point for this webinar. So all of you will get kind of letter provided by the company saying that you will have 1 credit point by the SGGG. Okay, so what am I going to talk about is here on my agenda. So I will shortly introduce the term genitourinary syndrome of menopause to you. Then I will focus on symptoms, the prevalence, and the diagnostic procedures. And then, of course, the focus of the presentation will be on treatment of vaginal atrophy, or the better term is genitourinary syndrome of menopause. So what's the definition of GSM? So GSM, the genitourinary syndrome of menopause, describes hypoestrogenic changes to the vulvovaginal and bladder urethral areas that occur in menopausal women. So this means, in contrast to the other term we used to use, vaginal atrophy, now the urinary symptoms are also included into this definition. There are several symptoms that can be related to genitourinary syndrome of menopause. And these symptoms, there are 3 complexes. So we have genital symptoms, sexual symptoms, and urinary symptoms. And genital symptoms, this is what we usually associate with vulvovaginal atrophy. So we have vaginal dryness, vaginal burning, and vaginal irritation. But now, due to this new term, we also have sexual symptoms we have to think about. This is lack of lubrication, discomfort or pain, and impaired sexual function. And we also have urinary symptoms such as urgency, dysuria, recurrent urinary tract infections. And if you ask yourself how often women are affected by GSM, you might be surprised how high the prevalence is. So we know that about 85% of women at age 40 plus report vaginal dryness. Almost the same number reports vaginal itching, and about 60% complain about dyspareunia. So that's quite a high number of women that is affected by GSM. And it's not only a local problem, but as you can see here, there's another study. It's a huge study from Italy showing that the genitourinary syndrome of menopause is also associated with a decreased quality of life in about half of women that present with symptoms. And even more importantly, there's another study showing last year that if women are symptomatic with GSM, they have an increased risk for depression and anxiety. And I think that's quite important because so many menopausal women present with depression and anxiety, and usually we just do not correlate this to vaginal or genital problems. And actually, that might be one of the reasons they have these kind of effective symptoms. So the diagnostic procedures are so easy. So it's just to take about personal history, including medication, because a lot of medication can also induce symptoms that are similar to GSM, such like antidepressants or antihistaminics, for example. So it's worth to have a closer look at the medication list. And then again, very easy, we only have to perform a pelvic examination. So we do not need huge amount of equipment to be able to diagnose GSM. And it's more about to be sure that there's no other pathologic condition, such as lichen sclerosis, which might induce similar symptoms. And what is also important to remember is that the intensity of the vaginal symptoms does not clearly correlate to the physical examination findings and also does not correlate to serum estrogen levels. So this means it's quite possible that you do your gynecological examination and you think, well, it doesn't look too bad, but if you ask the woman, then she might tell you that she has severe vaginal dryness or dyspareunia. It can also be the other way around, so that you do your gynecological examination and you think, oh my God, this must really hurt. And you ask the woman and she will tell you, no, actually there's no problem. So that's why it's necessary to ask and to do the gynecological examination together. So, and now I'm very, very happy that I can introduce to you the just updated position statement from the North American Menopause Society. It was published just like 3 days ago, and actually we were waiting for this position statement for a couple of years, because the first position statement by the North American Menopause Society about the genitourinary syndrome of menopause was published in 2013, so it always felt a little bit strange that we had to cite such an old paper. But now, since 3 days, we have a new position paper. But as you will see, there are not too many differences compared to the older one. So what about the recommendations the Americans have for us? So still, the first-line therapy for genitourinary syndrome includes non-hormonal products. And the Americans only know 2 non-hormonal products, namely lubricants that can be used with sexual activity and long-acting vaginal moisturizers. And as you can see here now, the new guideline also reports the level of evidence. So for this recommendation, we have a level of evidence A, which means it's a very good evidence available that actually lubricants and moisturizers are helpful. In case that lubricants and moisturizers are not enough, or that the symptomatic is so severe that you consider other treatment options, then we have second-line treatment options here. So again, first of all, you can see that all of these treatment options are graded as level A. So there's a huge evidence, scientific evidence that these treatment options are really working, and that there are enough studies, randomized controlled trials showing that the active ingredient is really efficient. So we have low-dose vaginal estrogens. We have, and that's new now in the updated guideline, we also have vaginal DHEA. Then the Americans also have a selective estrogen receptor modulator, that's ospemifene. We do not have it on the market, so I'm not going to focus on this more closely. And of course, we can also apply systemic estrogen therapy or menopausal hormone therapy if other menopausal symptoms are also present. But let's focus first on non-hormonal vaginal products. So here in Switzerland, we do not only have lubricants and moisturizers like the Americans, we also have emollients. Another word for emollient is cream. So, and as the Americans have already pointed out, lubricants are only useful for sexual intercourse. So they do not have a long-lasting effect. If you want to have a long-lasting effect, you either use moisturizers or you use creams. And those products are effective for up to 24 hours. And of course, you can use them also for sexual intercourse, but you can also use them for the other symptoms of genitourinary syndrome of menopause. So here's a list of just a few examples of vaginal moisturizers that are available in Switzerland. I think 3 of the most famous ones are GynoFit, Hydrocenter Biomed, and Multigyn Liquid Gel. And as you can see, they are all applied by applicators, and they have different kind of ingredients. We also have a vaginal cream, that's the Vagizen Feucht Cream, and it also comes with an applicator that can be used several times. And you are probably aware that there are tons of other creams available on the market, but usually the other creams can only be applied to the vulva and not into the vagina. And in order to use a cream for vaginal dryness, for example, It's also good to be able to put it on the inside and also on the outside. And here we only have one cream on the market. Now you might ask yourself if this is really true that a non-hormonal product is as good as a vaginal estrogen. And of course, several studies have been performed because otherwise it would not have reached level of evidence A. However, I think it's worth to have a look at what kind of studies were performed with moisturizers. In the US, one of the most popular moisturizer is Replens, and Replens has been compared to various vaginal estrogens. And usually, if you do a study with vaginal products, you always want to have a look at so-called objective signs of GSM. So objective signs are, for example, the vaginal pH or the vaginal maturation index or the vaginal health index. So all these indices means the woman does not report how she feels, but we as a gynecology, we do a gynecological examination and, for example, measure the pH. So that's objective. But as you already know, the objective and the subjective signs and symptoms do not correlate. So that's why it's necessary also to ask the woman what her most bothersome symptom is. Usually it's vaginal dryness or dyspareunia. So when we go back to the studies, we would like to know if a certain product has an impact on the objective signs of GSM, like pH changes, and or if the product has an impact on subjective symptoms such as dryness. And as we can see here, for example, for Replens, and this is also true for all other kind of hormone-free gels or products, usually the moisturizers are as good as vaginal estrogens when we focus on subjective symptoms such as dyspareunia, itching, burning, or dryness. And usually the moisturizers are a little bit less potent when we look at objective signs. But we can say, who cares too much about the objective signs? The most important thing is that the woman gets rid of her symptoms. So, and if this is provided by a non-hormonal product, then fine, then that's why it's a first-line therapy. Now we come to the vaginal estrogens. So vaginal estrogens are usually applied if the non-hormonal products are not efficient enough, or if the symptoms are so severe that we do not want to wait and waste any time, and then we start directly with vaginal estrogens. So in the US, they have on their market vaginal conjugated equine estrogens and vaginal estradiol and vaginal estrone. Here in Switzerland and in the EU, we also have estriol, and that's probably a kind of flaw in the American guidelines because they always only talk about estradiol, conjugated equine estrogens, but they never talk about estriol because they just do not have it. So here in Switzerland, we have estriol and we have estradiol. And we can apply them as cream, as suppositories, as tablets, and also as a ring. Usually the cream, suppositories, and tablets are applied daily within the first 2 weeks, and then twice weekly afterwards as a maintenance therapy. The only exception is the vaginal ring. This is applied and replaced every 3 months. And now on the lower part of the slide, you can see the different kind of application forms. And here I put on the respective applications forms what kind of estrogen is in there. So we have estriol cream in Switzerland. In Germany, they also have estradiol vaginal cream. Then the vaginal ring, that's the estring, contains estradiol. Then we have vaginal suppositories containing estriol, and we have vaginal tablets containing either estradiol or estriol. And What's also possible is that we categorize the vaginal estrogens depending on their dosage. So again, here we have the vaginal estradiol and we have the vaginal estriol, and then we can distinguish high dose, standard dose, low dose, ultra low dose. So standard dose, that's more or less the oldest product we have on the market. And right now we have the estrogenidrone cream and we have Ovastin suppositories. So if you apply them twice weekly as a maintenance therapy, that's like a standard therapy. If you use the vaginal ring that contains vaginal estradiol, this is a low dose vaginal estrogen therapy. And as you can see, in the past years, more and more products have come to the markets that are ultra low dosed. So here we have the Vagifem that contains 10 microgram of estradiol. We have Gynoflor and Kedofamine estriol ovula. They contain 30 microgram of estriol. And we have the Gelblis cell, which contains 550 microgram per application. And if you wonder how you should apply them in practice, here again you have the product name. You have here the doses, the starting doses for each product, and the last column tells you what the maintenance therapy looks like, so how often you are applying it per week in order to have an effect. If you now ask yourself if all these various and different kind of vaginal estrogens do have the same efficacy, the answer is yes. So the most recent Cochrane database analysis is from 2016, and here the authors compared or had a look at all studies that were performed with the respective vaginal estrogens, and they came to the conclusion that there was no evidence of a difference in efficacy between the various intravaginal estrogenic preparations when compared with each other. So this means the choice of treatment mostly depends on what the woman wants. What about safety? And here we also have good news, because there's no evidence of a difference, that there's a difference in respect to adverse events between the vaginal estrogenic preparations, and what is even more important, there's no difference in respect to adverse events when vaginal estrogens are compared to placebo. But on the other hand, not 100% of women will actually have an improvement if they are using vaginal estrogens. And that's actually no surprise in medicine, because you never have a 100% success rate. But the question is, for how many women do you actually have to expect that the vaginal estrogen therapy is not enough? And the answer is, going back to the Cochrane analysis, that just roughly said about 12 to 15% of women that are treated with vaginal estrogens will still have vaginal symptoms. And if this is the case, you can switch to another vaginal estrogen, but you can also switch to another treatment strategy. So coming back to the NAMS recommendations, this is more or less the same what was already said in 2013. So usually if you apply a standard low dose or ultra low dose vaginal estrogen, you do not have to add a progestogen for endometrial protection. So that's very important, because otherwise the woman would have to swallow something, and that's not necessary. So you can only apply vaginal estrogens, and that's okay. And that's of course still important, if a woman reads the package insert, she will read that the vaginal estrogens are not used forever. And that's mostly due to the scientific data about endometrial safety. So the official authorities like FDA or Swissmedic, they want the pharmaceutical companies to perform studies for endometrial safety for 1 year. And of course, no company will say, let's do a study for 10 years. So usually safety data is available for 1 year, and that's why the package insert is also limiting the application to 1 year. However, there's absolutely no data that's showing any risk, and that's what is also said here in the recommendations. So here they say that observational studies are reassuring regarding longer term use. So please do not stop the treatment after 1 year. Endometrial surveillance is usually not recommended if you keep to the dosage that is recommended. However, if the woman is using higher dosages or if she already has an increased risk of endometrial cancer, then it's a good idea to do some kind of endometrial surveillance. It's not clearly said what kind of endometrial surveillance should be performed, so you can do either transvaginal ultrasound or intermittent progesterone therapy. Personally, I prefer progesterone therapy, so once a year I would add progesterone in women that are at an increased risk of endometrial cancer. For example, dihydrogesterone, 2 pills per day for 14 days in order to see if there's a progesterone withdrawal bleeding. And finally, no surprise, if there's any spotting or bleeding, we have to take a closer look at the woman and to find out if there's any pathology within the endometrium. Then what I really like about the recommendation is this point here, that if again you have a look at the product labeling, you will find all risks that are associated with systemic continuously combined menopausal hormone therapy. So if a woman reads the insert, she will be panicking because she will read something about coronary heart disease, stroke, venous thromboembolism, breast and endometrial cancer. But in this updated guideline now, the authors are saying that it's highly unlikely that any of those risks are really realistic, because the systemic absorption is so low and no study until today has shown any risks that are noted within the package leaflet. And also, if we want to know if we can give vaginal estrogens to women with breast cancer, we can have a look at the most recent guideline from Germany, Switzerland, and Austria. And here, this was published this year, we can read that in breast cancer survivors, ultra low dose vaginal estrogens such as 30 microgram estriol 2 or 3 times per week is absolutely fine. There's a new product on the market, and this is called Intrarosa. Intrarosa contains DHEA, so that's a pro-hormone of the androgens, and one suppository contains 6.5 milligram DHEA, and this suppository is applied daily. So that's a huge difference to the vaginal estrogens, because with most vaginal estrogens, you will have a maintenance therapy of 2 or 3 times per week. That's different here with the DHEA suppository, because this is applied daily forever if you want. So DHEA has been approved by Swissmedic. It's going to be on the market next week, and it's still not clear if the health insurances are paying for it, but the company is still discussing with the health insurances to cover the expenses. So, and it will be about 30 francs per month. Another treatment option, but probably more likely for the future, is vaginal testosterone. So there is a group of scientists in Brazil that have performed a placebo-controlled, randomized controlled trial in postmenopausal women. And these women either received vaginal estrogens, vaginal lubricants, or vaginal testosterone 3 times per week. And one application of vaginal testosterone contained 300 microgram. And they had a look at several endpoints, for example, sexual function, and no surprise, 12 weeks of treatment with testosterone and estrogen improved sexual function significantly. Also, if we have a look at vulvovaginal atrophy or genitourinary syndrome of menopause and safety, again, vaginal estrogens and testosterone significantly improved symptoms and signs of vaginal atrophy or genitourinary syndrome of menopause, and most importantly, the endometrial thickness did not change during the treatment. They also analyzed serum levels of different kind of hormones and also metabolic parameters like lipids and liver enzymes. And again, during the treatment, there were no changes of any of those parameters within the blood. So their conclusion is that vaginal testosterone applied 3 times per week with a dosage of 300 microgram per application is very promising. And maybe it's also, or it's going to be an option for women who had suffered from breast cancer using aromatase inhibitors at the same time. But for this question, we only have like 2 studies. So this is too early to really give vaginal testosterone to those women. And now finally, we come to the vaginal laser. So the fractionated CO2 vaginal laser, you can see an example for the machine on the slide here. This laser is usually applied 3 times within 12 weeks. So 3 laser sessions, then always 4 weeks apart between the laser sessions, and in total 3 laser sessions that are applied to the women and that are also applied in most of the studies. And when I try to explain to women how the laser works, I always compare it to the anti-aging treatment for the face. So a lot of women have already seen or had also experienced microneedling, meaning that you are producing tiny holes within your face, which at the beginning looks a little bit dramatic, because here you can see a picture of a woman right after the microneedling, and you get the impression, oh my God, everything is inflamed. So that looks a little bit scary maybe, but on the other hand, just a couple of days later, you will see when the redness disappears that the face already looks younger, and that's due to the fibroblasts that are starting to produce collagen and hyaluronic acid because they were stimulated by the needles. And that's more or less how the laser also works within the vagina. So the vagina induces tiny holes within the vagina wall, and then the fibroblasts within the vagina wall start to produce collagen and hyaluronic acid. Now let's have a look what the science says about efficacy of the vaginal laser. And the first systematic review and meta-analysis that was published was in 2017. In this study, 14 studies were included, comprising more than 500 women. And most of these women were postmenopausal, suffering from genitourinary syndrome of menopause, and some of them also had urinary incontinence. And what all these studies found, and the meta-analysis found, was that there was a significant improvement of dryness, dyspareunia, burning, itching, dysuria, urinary incontinence, and sexual function. So this sounds wonderful. However, as always in those kind of reviews and meta-analysis, the authors came to the conclusion that 14 studies are not enough. So they are saying the quality of the body of evidence is low, and thus evidence-based modification of current clinical practice cannot be suggested. So this just means that still first-line therapy are non-hormonal vaginal products, secondary or second-line therapy are vaginal estrogens and DHEA, and that we still need more studies to be sure that we can rank the laser a little bit higher in this hierarchy. So let's have a look at a paper that was published at the beginning of this year by two scientific societies, and this again was a systematic review. So as you can see, the societies focused on several different indications, and you can also see here that most studies that had been performed with a laser were done in women with vaginal atrophy. And you can see that also studies were done in women with urinary incontinence, prolapse, vulvodynia, and lichen sclerosis. And if we have a look here at the studies that were performed in women with vaginal atrophy, we have now at least 20 retro and prospective case series. We have, at this point of publication, one randomized controlled trial. We have prospective studies, and in those prospective studies, they either used vaginal estrogens or a lubricant as comparator. And again, they came to the conclusion that the results are very promising, but again, they recommend that there's currently not enough scientific data demonstrating efficacy and safety of laser for treating vulvovaginal atrophy. And that's mostly due to the study design and the sample size of those trials. So here's the conclusion of the International Society for the Study of Vulvovaginal Disease and the International Continence Society. They say, although laser technology seems promising for selected indications, long-term efficacy and safety data are lacking. In order to elucidate its optimal clinical application, laser therapy must be evaluated in rigorous, well-designed studies that are of appropriate timescale, randomized, and sham-controlled. So this means the sample size has to be bigger, and they want the laser to be compared to estrogens and also to sham procedures. So, and on the last two slides, I would like to show to you just a selection of studies that have been published since this publication at the beginning of the year. And you will see that a lot of work is going on to finally fulfill the criteria of the scientific society so that the laser will be officially ranked as a third-line or second-line therapy. So first of all, now we have the recommended double-blind randomized controlled trial within postmenopausal women. They either received 3 times laser or sham procedures. And after 12 weeks of treatment, there was a significant improvement of the vaginal health index. That's an objective sign of genitourinary syndrome and also of vaginal dryness. So, of course, that's not a surprise, but it's one of the studies the scientific community would like to see. Then, what I also found very interesting, another study, it's a small one, also in postmenopausal women. No surprise, there was a significant improvement of vaginal health index and sexual function after 1 year follow-up. But what I thought is interesting is they distinguished between women that were quite after or shortly after menopause and women that were after menopause more than 3 years. And they found that especially women that are quite close to menopause, so within 3 years after menopause, that it's possible to restore the vaginal epithelium almost 100%. So it's worth not to wait too long. And then another study looking at pain, because I think a lot of women will be kind of afraid if they think about all the holes that are shot with a laser into their vagina. And in this study, they were analyzing the pain at different kind of positions of the laser, and then they had a overall pain score. And the pain score had a range from 1 to 7, and the mean pain score at the first treatment was 3.5, so some were on average. And this pain score significantly decreased until the third treatment. And the decrease of the pain is probably due first because the women, they knew what is going on. And also the restoration of the vagina wall had already started. So that's probably also one reason why it was less painful. The second slide about selected studies about the laser comes here. There were 2 more studies focusing on cancer. One study was focusing only on breast cancer patients, and the other study, this is the one I have cited here, looked at women that had suffered from cancer, but not only breast cancer, but also ovary, cervical, and uterus cancer. All these women received laser therapy for 3 times. And what I like about this study here, they give a percentage of improvement. So they found that the reduction of vaginal dryness was about 66%, burning was reduced by 66%, and dyspareunia was reduced by about 60%. So that's helpful for the practical, for the everyday practice, that we have some kind of numbers for the women if we want to, if we do consultation on management of vaginal atrophy. Then one study that looked at all the different kind of symptom complexes, genital symptoms, sexual symptoms, urinary symptoms, and they all improved with the help of the laser therapy. And finally, a comparison of laser with vaginal estrogens and a lubricant. So this is a randomized controlled trial, and the women were randomized either to laser, to vaginal estrogen, or to a lubricant. The study duration was 12 weeks, and 2 weeks later, the groups were compared to each other. And especially in this study, the urinary symptoms significantly improved with the help of laser. So this means there are 2 studies, one sham controlled and one estrogen controlled study. So hopefully the ranking of the laser will improve in next years. So I come to the summary. As you now know, 3 in 4 postmenopausal women present with symptomatic vaginal atrophy or genitourinary syndrome of menopause due to estrogen deficiency. The diagnostic, very, very easy. It's just a clinical assessment. First-line therapy, non-hormonal vaginal products like lubricants, moisturizers, or creams. Second-line therapy, vaginal estrogens, vaginal DHEA. And further therapy available, so far not covered by the health insurances, is the vaginal laser therapy. And still a little bit experimental or future therapy is vaginal testosterone, which, if you want to apply it now, has to be compounded in certain pharmacies. So now we can come to our discussion. Or before we start with the discussion, and if you want to have the presentation I just gave to you, you can just send me an email to gunendofoinde@gmail.com, and I will send you then the presentation. So that's the end of my presentation, and now I hope that I will manage the discussion. So I think you can ask directly or you can write your answer. And maybe we also will get some help from extern. I don't know. Let's see.
Yes, discussion is open. You think everyone can ask his questions? Are there no questions?
Or any comments?
Comments.
But everyone, I hope that everyone was able to hear something. Frau Stäuble,
No.
are you sure? Huh?
It should be open. Yes. Can you give us a hand sign if you can hear us? Oh.
I'm
No.
not so sure.
Okay.
But you think that they were all able to hear me?
They should.
They should.
Yeah,
Okay.
they should.
Okay. So as I said, you can you just send an email if you want to have the presentation, or if there were any problems with listening to the presentation. I'm pretty sure it was recorded, so maybe you can also get a second chance.
Is recorded.
Okay, good. Okay, so I think then we close the session, huh? Or what do you think, Frau Stäuble?
Yes, if we cannot. Okay, there come
maybe
some
you just
questions came in. They thank you for the nice what you did. Yes, and we cannot make question. Okay, I'm so sorry. Something doesn't make.
Okay, so then maybe we can, so if there are questions that for some reason we cannot hear or read right now, just also send your question to the günendofreunde@gmail.com email. Or you can, I'm pretty sure you can also send your question to Mrs. Stäuble and she can forward your question to me.
Of course, yes. So then we can come to an end if there are no questions possible.
Okay. Okay, so then have a nice evening, everybody.
Thank you very much.
You're welcome. Bye-bye.